next speaker, Priyanka.
Hi, I'm Bianca, one of the CPMC GI Fellows. Thank you all so much for joining us. It's my pleasure to introduce our next speaker, Dr. Todd Frederick, who is a transplant hepatologist at CPMC, where he also serves as a Director of Quality and Clinical Protocols for the division. His research interests include pathophysiology of portal hypertension, management of complications of advanced liver disease, and artificial liver support systems. He received his MD from New York Medical College and completed residency as well as his GI and transplant hepatology fellowships at UC San Diego. I know from personal experience that Dr. Frederick has a great talk planned for us tonight to discuss the very important and frequently encountered topic of AKI and cirrhosis. So welcome, Dr. Frederick.
Okay, thanks, Bianca, for the introduction. Dan, that was a great talk. It's always a challenge to follow interventional radiology and these symposia, all the exciting cases. So I hope this doesn't bore everybody following that talk. I was asked to talk about complications of liver disease ascites. I'm going to actually focus on acute kidney injury. I hope that's okay. Happy to field additional questions later on as well. So we'll start with background. AKI and cirrhosis, we have to deal with this a lot. We encounter it frequently. Roughly 20% of our hospitalized patients with cirrhosis will have diagnosis of AKI, and it associates, unfortunately, with an increased short-term mortality. Historically, AKI has been defined as an absolute threshold of serum creatinine, which has made it difficult to accurately diagnose some patients who clearly have acute kidney injury, but perhaps don't have the muscle mass to demonstrate the elevated creatinine. So a few years ago, the International Ascites Club adopted guidelines that the general nephrology colleagues were using for acute kidney injury that you're familiar with, and defining AKI as simply an increase in serum creatinine of greater than 0.3 milligrams per deciliter within a 48-hour period, or an increase by 50% within a presumed 7 days. And you can actually use a baseline creatinine within 3 months if you don't have one more recently, assuming the AKI happened acutely. So this takes away the need for a threshold creatinine of either 1.5 or 2.5, and being able to identify these patients sooner with a less extreme decline in their GFRs. When we see AKI in cirrhotic patients, I kind of immediately branch it into three different potential buckets. One would be the most common, which would be pre-renal. And this would include HRS as a form of pre-renal. These would also be known as functional renal insufficiency states. The second group would be intrinsic renal insufficiency, which would include things like acute tubular necrosis, glomerulonephritis, acute interstitial nephritis. And you could think of these more as a structural or a nephropathy as opposed to a functional. And then a very small third group would be the post-renal or obstructive group. Diagnosing these, good old-fashioned history-taking, physical exam. We administer fluid, both saline for volume-depleted patients. Albumin is recommended to identify patients with HRS, which we'll get into in a little bit. Urinalysis is certainly critically important. Renal ultrasound, urine electrolytes, with a caveat that the urine electrolytes really should be obtained at least 24 hours after a fluid resuscitation challenge. Hard to interpret. Also hard to interpret on diuretic therapy. And then occasionally we'll order urine eosinophils looking for interstitial nephritis. The fractional excretion of sodium is sometimes utilized. I don't use it very often. I do look at the urine sodium globally, but it's confounded by diuretics or the sodium avid state of our cirrhotic patients, sometimes hard to differentiate. Fractional excretion of urea can also be looked at. So when we talk about AKI now with this 0.3 milligram per deciliter increase, that would be stage 1 AKI. A stage 2 AKI would be someone with a doubling to less than a tripling of their serum creatinine baseline. And a stage 3 would be a tripling or more, or an absolute threshold above 4, or somebody who's needing initiation of renal replacement therapy would be stage 3. And then down below, a subtlety would be stage 1A can be broken down, or stage 1 can be broken down in stage 1A, which would be an absolute creatinine less than 1.5, or stage 1B, where they increase by 0.3 milligrams per deciliter and now eclipse serum creatinine of 1.5. And again, the baseline can be drawn anywhere within the last 3 months. So I mentioned this, the serum creatinine is we're kind of stuck with and is here to stay, but is certainly not the most ideal measure for estimating GFR in our patients, particularly our advanced cirrhotic patients, the frail patients that Jennifer is going to talk about. Their muscle mass is depleted, their serum creatinine release is reduced, and trying to estimate their GFR when comparing it to a person with normal muscle mass, it's much different. You can see the slopes of the curves here with the same serum creatinine. The estimated GFR would really be much lower in a cirrhotic patient, particularly one with ascites and sarcopenia, compared to a healthy subject. Cystatin C, I've seen some pretty good compelling data for as a different analyte that we could measure to estimate GFR. It's not widely utilized yet, but I think we'll hopefully hear more about that in the coming years to give us a better sense of estimating GFR. So as far as the etiology of AKI in our cirrhotic patients, this is an older study now. Guadalupe Garcia Sal put together multiple different series of patients hospitalized with cirrhosis and looked at the cause or the presence of either acute or chronic kidney injury, and then the causes, just to give a sense of what contributes to the AKI. And so you can see in this series, around 19% had AKI. And of that 19%, the majority were pre-renal, 2/3 of them, 1/3 intrarenal, most of which were ATN, some glomerulonephritis, and very few were obstructive. Within the pre-renal group, another 2/3 of those were considered volume responsive, which would be non-HRS, and then 1/3 were volume responsive, or I'm sorry, not volume responsive, and those would be the HRS patients, classifying them into type 1, which is now considered older terminology, a doubling or more of creatinine to a threshold of 2.5 milligrams per deciliter, or type 2, which would be a more gradual increase in creatinine and decrement in GFR in a more chronic phase. And you can see just the takeaway for this slide is that most AKI in cirrhotic patients is actually not HRS, it's a minority. I find this table helpful for differentiating those differences in cause of AKI, trying to figure out, is someone pre-renal, non-HRS, are they, do they more likely have ATN or other intrarenal causes, or is this hepatorenal syndrome? The urine sodium we talked about, it can be usually low in pre-renal. It can also be low in intrarenal. It's not always elevated, so it's not an absolute. The fractional excretion of urea is also helpful. Seldom ordered. I'll admit I don't look at this very often myself, but could be useful when you're trying to distinguish between ATN or pre-renal. And then this is more of a research tool, but of interest, the urinary NGAL may also be helpful, and I think we should hopefully be getting more information about this and potentially access to this clinically to help differentiate at an early stage whether someone's more likely to have ATN versus a pre-renal state, and then whether or not that's going to be volume responsive. So I mentioned the AKI diagnosis in a cirrhotic patient comes with an increased mortality. These are two different case series one an Italian case series, the other Spanish, looking at a 3-month timeline for patients with cirrhosis being diagnosed with AKI. Now, this is all types of AKI, not just HRS. And you can see on the series up on the top of the slide, top right, patients with AKI that was stage 1A, that's this orange line here, that was creatinines less than 1.5. Those patients actually had a equivalent survival to cirrhotic patients hospitalized without AKI. It's not until the creatinine eclipses 1.5 with either stage 1B or more dramatically stages 2 and 3 AKI that the mortality increases over a 3-month period. Similar findings in the Spanish cohort down here. Again, that creatinine 1.5, well, it's no longer necessary to define AKI, it still has importance for prognosis. One other takeaway on this slide is the newer diagnosis of AKI now, the 0.3 milligram per deciliter increase allows us to certainly diagnose patients earlier. In a review of the last turleypressin trial, looking back at the entry criteria for the patients in that trial, if the new criteria were applied as opposed to the older criteria, on average, those patients would have been diagnosed 4 days earlier and at a creatinine of 1 milligram per deciliter lower than they were in the study, and certainly would improve chances of responding to vasoconstrictor therapy. All right, so we've talked about AKI, we've talked about different causes of AKI. How do we define hepatorenal syndrome, which is a subtype in our cirrhotic patients? So it's a pre-renal AKI. I mentioned really an extreme example of pre-renal AKI, generally in patients with advanced liver disease, generally cirrhotic or with severe alcoholic hepatitis would be the other larger group that we see this. And the critical component is the portal hypertension. Most of these patients have ascites at baseline, making a diagnosis of HRS in the absence of ascites should be questioned. It's not unheard of, but it would be unusual. The hyperdynamic circulation should be present. These patients generally have a very low systemic vascular resistance and a high cardiac output. And they frequently have an underlying cirrhotic cardiomyopathy that is generally under-recognized or undiagnosed. The HRS patients, by definition, are not reversible with simple volume resuscitation. This is over a 48-hour period, and albumin would be required as part of this resuscitation, with or without saline, depending on how volume depleted your patient is. You should not have any evidence of intrinsic renal injury, so specifically no significant proteinuria. A 1+ on a dipstick would be reasonable, but beyond that would essentially rule out HRS, at least HRS in its purest form. Hematuria would also rule it out unless there was some other explanation like a traumatic Foley placement. And the ultrasound should be normal. If you see increased echogenicity of the renal parenchyma, that would point towards some other explanation. Certainly HRS can be superimposed on a patient with some degree of CKD, but it would not be pure HRS if their renal ultrasound is abnormal. Precipitating events are frequently identified, but not always, and we'll talk about some of those. And this still is considered a diagnosis of exclusion with the other competing diagnoses we talked about. I mentioned what are now considered the old classification of HRS type 1 and type 2, really the concept of doing away with these absolute thresholds for serum creatinine before making a diagnosis. Most experts that I've spoken with would consider HRS type 1 to be equivalent of an AKI at stage 2 or greater, and that's debatable. And then the old HRS2 we would now rename CKD HRS, or chronic kidney disease HRS, defined as over 12 weeks of impaired renal function. All right, the pathophysiology of HRS, predicated on portal hypertension, really. Not all of the patients will have cirrhosis, but most do. In the portal hypertension, there are endogenous vasodilators release, nitric oxide, carbon monoxide, endocannabinoids, glucagon, others, leading to an inappropriate vasodilation of the splanchnic arterial circulation. And this leads to what's sensed by the body as a decreased effective arterial volume. And so the body will react to that by compensatory mechanisms, which include the renin-angiotensin-aldosterone system, the sympathetic nervous system, and antidiuretic hormone or arginine vasopressin. And these eventually lead to severe renal vasoconstriction in addition to other systemic vasoconstriction. That renal vasoconstriction eventually causes a decline in the GFR, although the kidney tries to autoregulate and maintain a GFR for as long as it can. Part of the way it does that is by increasing the prostaglandin production. Part of the reason we should avoid NSAIDs in our cirrhotic patients with portal hypertension, because they're quite dependent on those prostaglandins to maintain their GFR with a reduced perfusion. There are usually secondary insults superimposed on this background hyperdynamic portal hypertension, generally in the form of infection or other injury with release of pathogen-associated molecular patterns, PAMPs, or damage-associated or DAMPs. These trigger an inflammatory response, which will further exacerbate the arterial vasodilation and potentially also intrinsically injure the kidney. And then the other one I had mentioned was the cirrhotic cardiomyopathy, where patients have this supranormal cardiac output at baseline, and then they're expected to augment that cardiac output even further to compensate for the progressive vasodilatation of the splanchnic circulation. They eventually can no longer meet that enhanced output. And that's at least one of the mechanisms that is believed to trigger HRS. So the precipitating factors, I mentioned infection, alcoholic hepatitis, very frequent cause, bleeding, excessive diuresis, although most of these patients, if identified soon enough, will be volume responsive. But occasionally they will develop HRS, which is not volume responsive. And then diarrhea, either innate or lactulose-induced, would be another potential trigger. But sometimes we don't find a trigger, so it's not actually required, but we should be looking. Initial management, again, early identification. If we can find these patients before they're needing dialysis, that's ideal. Look for the bacterial infections. The statistics would tell us that our cirrhotic patients are 5 times as likely to have an infection during their hospital stay as a non-cirrhotic patient. So I generally assume there's an infection until proven otherwise. And so ascites should be aspirated if at all possible and promptly. And then other cultures, and consider empiric antibiotics if your suspicion of infection is high. There's a recommendation to avoid large volume paracenteses up front in our patients being admitted with AKI. You certainly should do a diagnostic paracentesis, but try to limit it to 4 liters or less. Beta blockers should be stopped if the patients are coming in on beta blockers. Certainly any nephrotoxic medications, NSAIDs, diuretics, and patients should be aggressively volume expanded. Saline, again, if they're clearly severely volume depleted, and albumin would be required now for an accurate diagnosis of HRS. The guidelines differ a bit between stages 1 and 1A and 1B or more AKI. In stage 1A, so creatinine less than 1.5, it would be reasonable to simply decrease diuretics, treat underlying precipitating causes, and monitor. And if there's progression, then certainly diuretics would need to be held and more aggressive resuscitation would be required. Further diagnostics after the 48 hours of resuscitation to help you determine, is this HRS or other. The other would be managed according to that diagnosis. If it's HRS, then the treatment of choice would be vasoconstrictors with ongoing albumin. So moving along those lines, our treatments are pretty limited, unfortunately, for HRS. Albumin is recommended to be given up front at 0.5 to 1 grams per kilo, maxing out at 100 grams for our larger patients. And then subsequent to that, most would recommend somewhere between 25 to 50 grams per day. And then a vasoconstrictor is recommended. Midodrine is kind of the default option for us here in the US, a peripherally acting oral alpha-1 agonist. Octreotide is generally given with that, with the hopes that it's decreasing production of the endogenous vasodilators, such as glucagon. Norepinephrine is another option, particularly for our sicker patients in the ICU with a broader coverage, alpha-1 and 2, as well as beta-1 and 3 agonism. Vasopressin can be considered, but is not preferred given its side effect profile. But analogs of vasopressin, such as turleypressin, have been studied and are widely utilized outside of the US, primarily because it has more of a preferential V1 agonism as opposed to vasopressin 2 receptors. But also turleypressin has an extended half-life, which allows for bolus dosing outside of the ICU. This is a study looking at plus or minus octreotide compared to norepinephrine, a systematic review, meta-analysis. Initially, both were compared to placebo for effect on either mortality or reversal of HRS. And you can see that the midodrine octreotide studies showed no benefit in either mortality nor in reversal of HRS, unfortunately. Although, again, it is our de facto standard of care off-label here in the US. Noradrenaline or norepinephrine did not show benefit in mortality, but did show benefit against placebo studies in reversal of HRS. And then norepinephrine compared to midodrine octreotide directly did not show mortality benefit, but also showed reversal of HRS benefit, again, compared to midodrine octreotide. A little more on turleypressin. It's a vasopressin analog, functions as a prodrug with a longer half-life, so about a 3-hour half-life. It can be dosed every 6 hours as an IV bolus. Preferential V1A activity with the mechanism of action being splanchnic and portal vasoconstriction. So to counteract that vasodilation that was being caused by the endogenous vasodilators released from the portal hypertension. Over time, the vasoconstrictive property should allow a reduction or demonstrate a reduction in renin production and subsequently angiotensin and aldosterone production. And this over time should allow relaxation of that prominent renal artery vasoconstriction. So renal artery vasodilation, improving renal perfusion, improving GFR. All the studies that have looked at turleypressin for HRS have also included albumin for efficacy for oncotic pressure and support. So turleypressin alone is not recommended. There have been several studies utilizing turleypressin in the US. The most recent one was presented at the liver meeting, actually not this online year, but the year before. It was called the CONFIRM study. It was a randomized placebo-controlled study, 300 patients, so the largest HRS trial to date. 2-to-1 randomization, turleypressin given by bolus or placebo, with both groups being given albumin. The primary endpoint was what was considered a verified HRS reversal. And this required 2 consecutive serum creatinines that were both 1.5 milligrams per deciliter or lower. They had to be at least 2 hours apart. And for demonstrating clinical benefit, the patient had to be documented alive and free of the need for renal replacement therapy or transplant 10 or more days after the second creatinine. Patients could be treated for up to 14 days while awaiting this HRS reversal, or treatment would be stopped and considered failed if renal replacement therapy was required, or transplant, or if the serum creatinine was still at or above baseline by day 4. The primary endpoint was met in this trial. The verified HRS reversal with turleypressin was 29% versus approximately 16% in the placebo plus albumin group. Again, both groups getting albumin, statistically significant. One of the secondary endpoints was is demonstrated here, also being met, showing the durability of the HRS reversal out to 30 days. Again, statistically significant. This was an exploratory endpoint looking at incidence of or need for renal replacement therapy post-liver transplant. A lot of these patients in the study were transplanted, and you can see in the turleypressin group, a smaller amount were needing renal replacement therapy post-transplant compared to those who had received transplant on placebo. Turleypressin as a vasoconstrictor or vasopressor is associated with side effects and adverse events in the study are listed here. Of particular importance and novel in this study was the incidence of respiratory failure. You can see at 10%, doubling what was seen in the placebo group. This had not been identified, or at least not felt to be clinically significant. Prior studies, there were lower incidences, perhaps more common in the turleypressin arm, but had not been seen at this percent. And here's another slide looking at other serious adverse events in the study, turleypressin versus placebo. There also was a higher incidence of sepsis and multi-organ failure. Other studies have looked at turleypressin in comparison to midodrine octreotide. This was a randomized controlled trial, although non-blinded, much smaller numbers, 27 versus 22. And this was a group of patients who met criteria for HRS1, as well as some that were HRS2. Unlike the bolus infusion or bolus dosing, this was by continuous infusion, which is often utilized outside of the US. And they showed much higher incidence of either complete response or a combination of partial and complete response for HRS reversal as compared to midodrine, which showed some partial response, but very few patients with complete response in the midodrine octreotide group. Turleypressin also compared directly to norepinephrine in this study recently published. This showed benefit for turleypressin in both HRS reversal and also surprisingly, and this was an acute on chronic liver failure population, surprisingly also the first study to show mortality benefit with one specific treatment over another in HRS. So finally, I'll comment on a couple of small case series with this concept. One of the concerns that's, I think, appropriately raised in our MELD era in transplant and treating these patients with HRS is whether we're actually doing them a benefit by trying to reverse their HRS if they're headed for transplant, have a high MELD. One of the arguments in support of using a vasoconstrictor in this population would be looking at what happens post-transplant, and perhaps improving GFR as patients head to transplant may be beneficial for them. So this case series, renal function predicted post-liver transplant outcomes, and this was actually survival outcome. So patients with more impaired renal function heading into transplant had overall worse survival. Another study showing HRS with dialysis dependency. Part of the reason most of these patients would be converted to simultaneous liver kidney transplants because of worse survival when requiring dialysis post liver transplant. All right, so in summary, AKI and cirrhosis, it's important, I think, to be familiar with new diagnostic criteria, no longer waiting for creatinines to eclipse 1.5 or even 2.5, but being able to diagnose it earlier with a delta of 0.3 or greater. Familiar with the staging terminology that's been proposed in the new guidelines. And then remember the differential in AKI and cirrhotics. And I find not all AKI in cirrhotic patients is HRS, and in fact, most of it is not if you're resuscitating appropriately. And I fully believe that there's often more than one etiology to the kidney injury, particularly a lot of our NASH patients with underlying metabolic syndrome may have pre-existing CKD with superimposed HRS physiology. HRS, certainly a devastating complication for our cirrhotic patients, particularly in our acute on chronic liver failure and our alcoholic hepatitis patients. Early recognition may help improve treatment response and outcomes. The new diagnostic criteria can help expedite this. Our current available treatment in the US, I was hoping to show you, is of limited efficacy. Unfortunately, I think norepinephrine has some stronger data. Midodrine octreotide has very little data. I think may be really based on its albumin use. Turleypressin looks to be superior to other vasoconstrictors. Unfortunately, is not yet FDA approved and not available to us here in the US. Certainly liver transplantation for suitable patients is the best treatment option. I would not argue with that. And perhaps improving renal function leading up to transplant can improve short-term mortality and maybe even improve post-transplant outcomes. All right, so I will stop there.
Great. Thank you, Dr. Frederick, for a great talk and for really nicely outlining your management and approach to these patients. We have quite a few really great questions, but we only really have time for one. Perhaps you can address the others in the chat later. That would be great. But when are you comfortable restarting diuretics in patients with AKI? And have you ever, or do you ever restart beta blockers after a diagnosis of HRS?
Yeah, good questions. The diuretics is challenging. You know, I think part of that depends on if there was some event that you intervened upon, an infection, bleeding, versus patients who are coming in with more of the so-called type 2 or CKD. Those patients, it's really challenging to get them back on diuretics. And I think, as Dan's talk pointed out, we're probably better off sending them to IR if they're candidates. But I will, particularly if I intervened upon an event, I will try to introduce diuretics after recovery of the AKI. The beta blockers is still a bit controversial. I do think the beta blockers help with reducing long-term risk, certainly variceal bleeding, but perhaps other mortality benefit in our cirrhotic patients working on that hyperdynamic circulation. It's challenging. Patients don't tolerate them very well. But I would, particularly if they have the blood pressure to support it, a systolic pressure at least above 100 would be somebody I would consider reintroducing the beta blocker.
Okay, great. Thank you. So I'd like to